Welcome to Bloodline Breakthroughs, Innovations and Inspiration. My name is Elissa Baldwin, and I'm the Director of National Patient Education at Blood Cancer United, formerly the Leukemia and Lymphoma Society, and I will be your host today. We welcome you to our video podcast or vodcast and hope you will join us for future episodes where we will discuss the latest advances in treatment for blood cancer, as well as hear inspirational stories from blood cancer patients and survivors. On today's episode, we will be speaking to Dr. Sameh Gaballa, a hematologist-oncologist and associate member in the Moffitt Cancer Center Department of Malignant Hematology in Tampa, Florida. His clinical interests are in treating patients with lymphoid malignancies, including chronic lymphocytic leukemia, or CLL, Hodgkin lymphoma, and non-Hodgkin lymphoma. Dr. Gaballa is also interested in incorporating novel approaches, such as CAR T cell therapy and bispecific antibodies. Welcome, Dr. Gaballa.
Thank you, Lisa. My pleasure to be here.
Well, thank you for being here. So, our topic today is on chronic lymphocytic leukemia, or CLL. Could you tell our viewers what that is?
Yeah, so chronic lymphocytic leukemia is a very common disorder, and it's very different than acute leukemia. So this is a chronic leukemia that most of the time is picked up incidentally, and what that is it's a type of very slow growing cancer that involves the lymphocytes. Lymphocytes are basically white blood cells, and their normal function is they're part of your immune system, and they fight cancer cells. So if they fail to die, they start accumulating in your blood. Yes, it is a type of cancer, but it's very slow. And most of the time, it will be picked up incidentally. You'll notice it in the blood counts. It can, cause lymph nodes to be enlarged. And we could talk about it further, today about how it presents and how it's treated. But again, it's the most common type of blood cancer, and it's very slow. It's very different than an acute leukemia, which is something that's completely different and needs to be treated and whatnot. So this one is very different.
Yeah. We also hear about small lymphocytic lymphoma, or SLL, when we talk about CLL. Is there a difference in CLL and SLL?
Yeah, so CLL is much less common, and basically it's basically the same disease. So if it's CLL, it's basically you're picking it up in the blood. Now there is a small minority of patients where you're not going to find it in the blood, and you're going to only see it in the in the lymph nodes. So that would so you present with lymph node enlargement, you find those B cell lymphoma cells in there. So we just call it not CLL, chronic lymphocytic leukemia. Leukemia means that it's in the blood. So this is called small lymphocytic lymphoma. Again, exactly the same disease, but it's only in the lymph nodes. It's not involving the blood.
Okay. And then we'll get into treatments in a little bit, but so are they treated the same then, whether it's CLL or SLL, or are they treated differently?
Yeah, for the most part, they're treated exactly as the same disease. I mean, sometimes obviously the reason to treat might be a little bit different, but for the treatments themselves, they're the same. Again, it's the same type of cancer. It's just one of them is mostly in the blood, the other one is mostly in the lymph nodes. Now, if it's in the blood and the lymph nodes, we still call it CLL.
Oh, okay. Now, what are some common signs and symptoms that a patient could have prior to diagnosis, and how do patients usually end up being diagnosed?
Yeah, so most of the time patients don't have any symptoms, and
Oh,
they usually you would find this incidentally, meaning the patient is going seeing their primary care physician for routine blood work. They notice that their white blood cell count is elevated. They go see a hematologist. They do a workup and they identify it. So that's usually the most commonly way it is diagnosed, which is incidental. Now, of course, there are patients that may present with symptoms, particularly if they don't see their primary care physician, they don't get routine labs.
yeah.
So, if they've had it for many years and it's just been brewing in the in the background, maybe they'll present with symptoms. So, for example, symptoms of if it causes anemia, then they might start having, shortness of breath. If it causes low white blood, if it causes sorry, low platelets, they may have, bleeding, issues or susceptibility, although that's not very common. What's also very common is sometimes patients will notice an enlarged lymph node, a lymph node is like
Mm,
a gland under your in your neck area, under your armpits, in the groin area, and then they get evaluated, and they find, either they get a biopsy or they get blood work and it's identified at that time. So that's usually the most common ways that this is usually diagnosed.
mhm. Now, before we get into current treatments, with CLL being a chronic cancer, what is the goal of treatment? Is the goal more controlling the disease and symptoms for a better quality of life, or is it curable?
Yeah, so that's an excellent question. So it's not curable in the sense that, you do a treatment for a set time and it goes away and never comes back. There are some other, cancers and lymphomas, for example, that, they're just treated and, they're cured where they go away and they never come back. Um, that is not the case with chronic lymphocytic leukemia. It's more of a chronic disease. We have the treatments have improved so much in the last, 10 plus years. And but the treatment still put it in remission. Okay.
Mhm,
But they're not going to cure it. So you do the treatments, it goes into remission. Um, all the symptoms go away. Um, but, later on, it can come back again. And for that reason, we don't usually, treat everybody.
yeah.
Some patients, or actually a lot of patients, when they are found, with this, will have this, just incidentally identified, as I mentioned.
Mhm,
So technically, if it's not causing them any problems, there's no advantage in, treating it early. The treatment is not gonna, cure it. Typically, the goal of therapy here is to uh, fix an issue, meaning that if the patient has a symptom or has a problem like anemia or low platelets, then yeah, then that's a reason to treat. But if this disease is not causing them any problems at all, they're not going to feel any different. After you treat it. So, what is the goal of therapy? To summarize, the goal of therapy is basically just for the patient to have a good normal quality of life. They don't have anemia. They don't have low platelets. They don't have big lymph nodes that are bothering them. So it's really symptom control and improving their quality of life.
mhm. Yeah, and we often hear from CLL patients that waiting for progression or being in that watch and wait or active surveillance period, it's kind of like they're waiting for the other shoe to drop, and that can be emotionally difficult for a lot of patients.
That is true, but you see, once the patient kind of understands, what we're trying to achieve and what the goal is, I think it takes a lot of the, an anxiety away. Watch and wait does not mean ignore. If the patients have no symptoms and there's no problems at all, they can start treatment, but they're not going to feel any different. They might get side effects from the treatment, and there's not really going to be any advantage in that regard, treating, patients early on. Is during the watch and wait, we're gonna wait until they have, you know, uh, like a lot of symptoms and, then they're gonna be sick at that time? The answer is no. We're watching it closely. And once we start seeing that, hey, this might start, causing issues, or it's about to cause issues or causing some issues, then yeah, then we'll go ahead and treat it. But you see, the most important part is there are many patients who will never need treatment for this in their lifetime, and I think that is, I think, the most important thing to think of. That, hey, yes, you do have this chronic disease, but you may not necessarily need, therapy for this. This not might not cause you any problems, and just treating it now may cause you issues when in fact you might have lived all your life without needing, any treatment or having any
Mhm.
problem from this. So that's usually, and once they kind of understand, the logic behind it, and that they're not being ignored. That every couple of months you're going to get your blood checked. You're going to see your physician, and if there's any reason to intervene, we do have a lot of treatment options if needed.
Yes, and that is a good reminder too for patients to communicate with their doctor about their treatment and options available, and really what is the best thing for them. Because if they don't need to be treated right away and could just go on active surveillance, which is a treatment in itself, then that is the best solution for them, and it's good for them to understand that.
Exactly, exactly. So, I think a lot of it has to do with, with patient patient education, not only patient but also family education, because sometimes the patients will come in and their family members will get anxious because maybe they're not in the same visit, and they might have a hard time grabbing the concept that, hey, so I you're telling me that I have a cancer and we're not doing anything about it and we're just going to watch it. Obviously
Yeah.
that's different, but you have to understand not all cancers are the same. Some of them may cause problems, some of them are chronic, and they may never cause any issues. So I think that's just once there's better patient understanding and patient education, I think that takes off a lot of the anxiety for the patient and their family members.
Yes, absolutely. Now, you have now talked about watch and wait or active surveillance. So, what are the other current treatments for CLL? It certainly seems like you mentioned before that treatments have really changed, particularly over the past decade.
Yeah, no, exactly. So the treatments have got completely changed. So when do we treat? So obviously there's guidelines, and the most commonly used guideline that we look at is the IW 2000 IWCLL 2018 criteria. And basically what it is if the CLL is causing symptoms or about to cause symptoms, then we treat. The most common reason will be, anemia, low platelets, very big lymph nodes, very big spleen that are, either symptomatic, giving the patient symptoms or bothering them, or they're about to give them symptoms. If, say, there's a big lymph nodes close to an important structure, you don't want it to, press on it and then, try to scramble for treatments. So that's really the indication, for therapy.
Mm.
Um, Sometimes, we also, that's a very common thing. So the patients will come in every visit while they're in the watch and wait. And when they look at their CBC, which is the blood test that we look at the blood numbers, their eye will fall on the abnormal white blood cell count. Okay.
Yeah.
And what I'll tell the patient is, we don't typically treat you based on the white blood cell count. I know that's what it says on the report, that this is the abnormal number. The expectation is that that number will, every time you come in, will slowly go up. That's the white blood cell count number. But we don't really jump on treatments based on that white blood cell count. What I'm looking at is the hemoglobin, the platelets.
Oh,
When do I decide on treatments based on the white blood cells? That's not going to be very common, but sometimes you'll get these patients where their numbers are doubling very quickly. And for us, very quickly is 6 months. Okay, so and we're not talking about the total white blood cell count. We're talking about the lymphocytes, which is the abnormal, part of the white blood cells, because there's other
oh,
white blood cells. So if it doubles in less than 6 months, that is technically one of the reasons that we would consider treating patients for. And that is based on the fact that most patients who have a rapid doubling count less than 6 months, most of these patients will, within the next couple of months, within a year, will start having anemia or low platelets. So for that reason, we can consider treating patients for that reason. So, what are the treatment options and how do we do it? So, we first of all we establish that, hey, okay, you have a reason to treat, and then we talk about treatment. So, in the past, before 2015, it was mostly chemotherapy plus immunotherapy. So, one of the things that were common back then was a regimen called FCR. There was also another regimen called bendamustine rituximab. Nowadays, it's very, very rare for us to go for these, for these regimens. And the treatment options, we keep on getting more and more treatment options. So there's BTK inhibitors, there is BCL2 inhibitors, there is combinations. But typically, what I tell patients is, okay, so we have a lot of options now, and they all work. Okay, so we just kind of have to you know, discuss the treatment options with you. We got to pick one, but you could think about it as there's two big approaches. There's
Mhm.
going to be the continuous therapy option, meaning that you start treatment with a pill, typically a BTK inhibitor. We have the first generation BTK inhibitor was ibrutinib, but then we have second generations of zanubrutinib and acalabrutinib. Those are going to be, Brukinza or Calquence. And it's a pill. You just stay up, you take it, it fixes the underlying problem. But then you just have to stay on the medication
Mhm.
indefinitely, meaning that it's either it stops working or you have a side effect from it that you need to stop. So that's the continuous treatment options. Um, and then there's a time limited option where you're doing
Mm.
treatment for a set amount of time and then you're stopping. And the most commonly used one was the combination of a medicine called obinutuzumab. That's an infusion.
Mhm.
The trade name for that is Gazyva. And it is combined with another pill, venetoclax. It's a BCL2 inhibitor. That's how it works. And you do that treatment for about a year and you stop. So it's a pill plus an infusion for a year
Okay.
and then you stop. But then recently, we also had another approval for another fixed duration therapy, which is fixed duration, but instead of the infusion, no, you're doing two pills. So you're starting out with a BTK inhibitor, you do that for some
Oh.
time, um, and then afterwards, you add venetoclax to it, and then you do a total of 1 year therapy. And I'm happy to kind of get into the differences between these approaches and the pros and cons for each approach, and what also are the unknowns that we don't know, and what are the ongoing clinical trials to try to answer those questions.
Yeah, I'd love to hear more about the pros and cons of doing a continuous versus a time limited or fixed duration. And then also what happens after that fixed duration? Are they going then into active surveillance?
Yeah, excellent question. So yeah, once you're done with a fixed duration therapy, then yes, you go back, you don't, you go to the patients, most of them go into remission, which is
Mhm.
basically I tell patients that this is like, a deep sleep. So you're not seeing it, it's sleeping deeply. At some point, you'll start seeing again those white blood cell counts start to come back in the blood, but it could be many years. It could be, 6, 7 years out or even more
Yeah.
sometimes. So yeah, so once you're done with that time limited therapy, you go back into surveillance. You don't ignore it. It's not cured. It probably
Mhm.
will come back. But again, sometimes it takes, a long time for it to come back. And, sometimes patients will die from something else before they ever see it, come back again. All right. So let's talk about, the pros and cons of, time limited therapy versus, continuous therapy. So, the main advantage for continuous therapy is going to be two things. One is the convenience factor. Okay.
Yeah.
So it's basically a prescription. It's going to go to not to the regular pharmacy. It goes to a specialty pharmacy. It gets shipped over,
Mhm.
and then you start on the medication. It doesn't have a lot of monitoring requirements. You don't need a lot of visits afterwards to do monitoring and whatnot. Typically, yes, initially you'll see your physician or provider a little bit more frequently in the beginning. Just make sure you don't have any unexpected side effects. Your blood work is not showing any, unexpected, side effects as well. Make sure it's not affecting your liver or, any of your other numbers. Just make sure you're on the right track. But then afterwards, less visits. So the convenience factor here is easy. You get a prescription, you start on the medication. You don't need a lot of visits back and forth, just some monitoring here and there. So it's very easy to start initially. So that's the number one advantage. The number two situation where we would try to consider continuous therapy is patients with CLL are not all the same. Okay, so some of them will have, you know, better prognostic things, and some of them might have some genetic features that makes them quote high risk. What does high risk mean? Well, the remissions are shorter. The likelihood of response is it might be lower, and the one that's notorious there is called 17p deletion or a TP53 mutation. So what exactly is that? So in our body, we have chromosome number 17, and on the chromosome there's a gene called TP53. And that gene normally protects the DNA, normal cells or cancer cells. So if that gene is either missing, so that's called 17p deletion, the chromosome itself is just, part of
Oh.
the arms of it is missing, or the chromosome is there, but the gene is scrambled, it's mutated, it's
Mhm.
damaged, so it's not working. So what happens is, so that gene normally what it does is protects the DNA, meaning that if there's any DNA damage, it helps to repair it. If the damage is irreparable, it tells the cell to self-destruct. Okay, so if that gene is missing or it's broken, then the cell, does not have that functionality, meaning that the CLL cells can acquire more and more mutations unchecked, cannot be repaired, and the cell does not also self-destruct. So that's why it makes it a little bit higher risk. It can also transform to more aggressive lymphoma more frequently. So for those patients, we would suggest a continuous therapy, just to continuously, maintain
Mhm.
suppressing, that high risk CLL clone. Now, having said that, patients still do well with a fixed duration therapy, meaning that in general, they'll still be in deep remission for a few years with a fixed duration therapy. The trial that that got that regimen approved, it's the CLL14 study. The average was, for people with the high risk, 17p deletion or TP53 mutation, it took them about 4 years for it to come back. Now, that's average, meaning that there are
Mhm.
patients who would stop the fixed duration therapy and then right away you're going to start seeing the counts go up. So then you know that this patient is not a good candidate for a time limited therapy. But on average, it took them still about, 4 years. However, for these high risk patients, we still would recommend a continuous therapy with a BTK inhibitor. Um, so those are the two situations where we would, those are kind of like the two advantages of the continuous therapy. What about the time limited therapy? Obviously, the big advantage there is you're doing a treatment for a year and then you stop treatment. Okay.
Mhm.
And that has a lot of advantages. You don't, you're less likely to have, side effects on the long run. Also, financially it could be better because if you're doing a treatment for, 1 year, then you don't get all the copays later on. So that's also sometimes something to keep in mind. So what's the disadvantage? Why don't then, if that's the case, why don't we just go ahead and do that for everybody? And why is continuous therapy one of the options? Well, so it's very inconvenient in the beginning, okay, because that combination of the two medicines is very effective, which sounds great, and it is great indeed. But the
Mhm.
problem is sometimes it would kill a lot of those cancer cells very quickly in the beginning. And what that would do is those dead cancer cells would release acids in the blood, and that acid can clog up the kidneys if it's not monitored appropriately. So for
Oh.
that reason, um, initially patients would get the infusions. The infusions is once a week for 3 weeks, and then afterwards it's once a month. And you don't start the pill right away, the venetoclax. So once a week initially for 3 weeks. And then during the second month is when you add the pills, the
Mhm.
venetoclax. But you don't start the pill the full dose right away because of that, acids, the uric acid problem that I was telling you about. So you start with a smaller dose, and then every week you go up slowly on the dose until after 4 or 5 weeks you get to the full dose. But that also means, and every time you're coming in to go up on the dose, you're getting the blood checked, monitored, to measure the uric acid in the blood. Sometimes patients will have a lot of disease initially, and even sometimes we'll recommend to admit them to the hospital with their very first treatment to watch their counts and monitor their uric acid,
Mm.
initially. So for that reason, it's a bit inconvenient in the beginning because if you think about it, those patients are going to be, seen about once a week. They're going to be seen for the first 2 months, and then they're also going to be going to an infusion center to get an infusion. Now, if you do it with the two-pill approach, which is the BTK inhibitor plus the BCL2 inhibitor, it's a little bit more convenient because you skip the infusions to the infusion center. So, you're
Oh.
going to do the
Mhm.
pills initially, but still, when you start the venetoclax afterwards, that pill, there's going to be that ramp up, meaning that you're going to need to see your provider once a week for 4 weeks or so, or 5 weeks initially. So it's a bit better in terms of convenience when you're doing the two pill approach. Now there are some patients where they would be good candidates for one versus the other, meaning that sometimes. So one of the issues, for example, with BTK inhibitors is they have a small chance of causing atrial fibrillation, which is irregular heart
Mm.
beats. Electricity in the heart sometimes can cause irregular rhythm, basically, or BTK inhibitors can increase bleeding risks. So if you have patients already coming in with significant heart problems, blood thinners, on Coumadin, sometimes those are not going to be ideal patients for a BTK inhibitor. And in that situation, that's easy. You could do the time limited therapy. Sometimes you'll see patients who come in and they tell me, "Hey, doctor, I'm for my job, I need to travel, once a week. I'm going to a lot of places, and just staying in one place for weekly visits for the first, 2 months or so. That's too much for me. Even if I do the two, pill approach, and maybe it's just 4 weekly visits during the second month. I'm sorry, during the when we introduced the
Mhm.
the venetoclax, that's still a lot.
Yeah.
Sometimes, yeah. So for them, it's easier for them just to start, a continuous BTK inhibitor. So one question that I get asked a lot about is, well, which of these is better? Should I do a continuous therapy? Should I do a fixed duration with two pills? Should I do a fixed duration with the, pill plus the infusion? And the answer is, we don't know for sure, but just last December at the American Society of Hematology meeting, there was an important study presented. So that's the CLL-17 study. And they did not use acalabrutinib or zanubrutinib. They used the ibrutinib, which is the older BTK inhibitor. But again,
Mhm.
it's still a very good study. So in that study, they had patients randomized, meaning that the computer randomly assigned them to a treatment group. So they either did a BTK inhibitor continuously, which was the ibrutinib, or they did the ibrutinib plus venetoclax, which is the two pill approach, or the venetoclax obinutuzumab, which is the pill plus the infusion. And those are the three options that I'm talking to you about. So with a follow up now of an average of 3 years, all the patients did the same. Okay, in
Mm.
terms of effectiveness. So they're
Mhm.
doing great. Now, there's a subset of patients who have those high risk features that we're talking about, the 17p deletions, TP53 mutations. They seem to have done better with the continuous therapy with the ibrutinib, which we already know,
Mhm.
and it makes sense. But again, um, it's maybe a little bit better, but still the patients on the fixed duration arm, still a lot of them are doing great with that approach. So maybe in 5 years, 10 years follow up, maybe you're going to start seeing differences between those groups. But as of right now, the three approaches are good. So typically, I tell patients, listen, so all of these will work, and you just have to kind of see what fits your lifestyle, what fits your other medical conditions that you have right now. That typically we talk about that as well. So you're basically just trying to pick between uh, you know good options. Um, there is one more thing that's there's some very sophisticated patients will come and tell me, well, Dr. Gaballa actually looked at the trial, and there's this new technology called MRD minimal residual disease.
Hmm.
And from different trials, it seems that the deepest remission. So what is MRD? So basically, we measure sometimes we look under the microscope, we can't see any cancer cells. We do our regular tests, we can't find it. But there's more sophisticated tests that can look for that cancer DNA in the blood, and they could find either one cancer in 10,000 cells or one cancer cell in 1 million cells. So it's very deep. So it's very sensitive. And what we could see is, at least for now, that the infusion plus venetoclax seems to have the deepest, undetectable
Oh.
disease in the blood compared to the other approaches. But again, what does that mean clinically? Because at the end, even if the minimal residual disease is positive, these patients can still, for many years not have any issues and no
Yeah.
anemia, no low platelets. And there's ongoing studies going on right now. So, for example, there's the MAGIC study that is comparing acalabrutinib plus venetoclax. So, acalabrutinib is Calquence. So, two pills, acalabrutinib, venetoclax, and it's compared to um, obinutuzumab venetoclax. So that trial is still ongoing, and it will compare those two approaches because, again, the CLL-17 that I just mentioned
Hmm.
used the ibrutinib, which is the older BTK inhibitor. So there's more data that's coming up. There's more follow-up that we'll do. But again, the bottom line is all those approaches will work. We just have to kind of see what fits your lifestyle or your preferences or as I mentioned, the medical issues that you might have that may impact our decision.
Hmm. Yeah, and I did want to ask about some other popular treatments that I know are approved for other blood cancers, and I wanted to see if they might be approved for CLL treatments. So CAR T cell therapy, bispecifics, and also stem cell transplant. Are those available for CLL patients?
Yeah, so there's going to be a small percentage of patients with CLL that will progress on a BTK inhibitor, a BCL2 inhibitor, which is venetoclax, and then they'll need other novel approaches.
Mhm.
The percentage of those patients is not big. Those are typically patients who were diagnosed when they were in their 40s and 50s. They've seen multiple therapies. They've seen a BTK inhibitor. They've seen a BCL2 inhibitor, and now they're relapsing again. You have to
Okay.
remember sometimes the CLL develops a mutation, particularly in patients who were previously treated with chemotherapy, because chemotherapy can damage DNA. So those patients can sometimes acquire a 17p deletion, and then afterwards they get more mutations that make them resistant to BTK
Oh.
inhibitors, BCL2 inhibitors. And those are the patients that we would look for other novel things. So bispecific antibodies are currently not, quote, approved for CLL, FDA approved. Um, but before we get there, there's FDA approved options. So non-covalent BTK inhibitors are, now approved for those patients. So that's something like pirtobrutinib,
Oh. Mhm.
so that's currently the non-covalent BTK inhibitor that's approved in this setting. And it's a BTK inhibitor, but it works differently. So it's not affected by that, notorious mutation that makes acalabrutinib or zanubrutinib not work. So
Mhm.
that typically we would recommend going that route first before we think about, other options like bispecifics, antibodies. Bispecifics are not approved in CLL as of yet. And how do bispecifics work? So basically, it's an antibody that has two ends, and it acts like a magnet. It's an infusion that you get, and it basically has two ends. So one of the end attaches to the T cells inside the body. So those are different category of your immune cells,
Mhm.
and their normal function is to actually fight infections, but also fight cancers. So that antibody basically holds on to the T cell inside the body, and then the other end attaches to the cancer cell. So it's like a magnet. It pulls your immune system to go and kill the cancer cell. And that's currently approved in lymphomas and multiple myeloma, even lung cancers. And but it's not FDA approved in that setting. CAR T cell therapy is approved in patients with CLL.
Mhm.
Um, Again, for those who have previously failed, multiple lines of therapy. So that's also available. So what is CAR T cell therapy? Well, those same T cells that I was telling you about, we collect them. We have the patient donate their own T cells. We collect them. We ship it off to a company. They put a sensor on it through a gene therapy, and then they expand those cells, make a lot of clones. And they're gonna be like like the army of the clones in Star Wars, and then you get them back, and then you get the infusion of your modified T cells, and they go in and hunt down those cancer cells. So that's approved in CLL. It's also
Okay.
approved in different types of lymphomas as well as multiple myeloma. Um, there's also other things that are, on the horizon, not FDA approved, but there's a lot of investigational things that are being looked at, and I'm happy to get into them as well.
Okay. So let's get into them then. So let's talk about the future of treatments for CLL. Are there any emerging therapies or clinical trials that you're particularly excited about?
Yeah, I think the closest thing that right now seems very promising is what we call BTK degraders. Okay, so when we talked about ibrutinib, acalabrutinib, zanubrutinib, these are the covalent BTK inhibitors. We talked about pirtobrutinib, which is a non-covalent BTK inhibitor. It's just again a BTK inhibitor. It works a little bit of a different way. But all that family, what they do is they inhibit an enzyme inside the cell called the BTK enzyme. Okay.
Uh-huh.
There's a new category of medications called BTK degraders or BTK destroyers. And what they do is, so inside the cell, there's actually machinery that destroys proteins. Okay, it's like a trash can, and the way it works is inside the cell, there are ways that the cell identifies proteins that should be destroyed or put in the trash. So they're tagged. And once they're tagged, they're thrown into this machinery called proteasome. And basically, it destroys that protein. So there's a
Oh,
medication that can help tag the BTK enzyme so that the cell recognizes that this is actually, trash. And it would basically destroy the whole enzyme. So that avoids the problem with BTK mutations that make them resistant to BTK inhibitors. So I think that looks very promising. I've definitely had patients in clinic on those clinical trials with 17p deletion, BTK mutations, BCL2 mutations, basically making them literally resistant to all approved BTK inhibitors and BCL2 inhibitors. And I've seen remarkable responses from some of those BTK degraders. There's also a newer BCL2 inhibitor called sonrotoclax that's currently being investigated in CLL. It was just approved, I think, yesterday or the day before yesterday in mantle cell lymphoma by the FDA. Not approved yet in CLL.
mhm.
So sonrotoclax is a BCL2 inhibitor, so it's similar to venetoclax. And we're just going to obviously have to wait to see how the newer data and newer information pan out and see how that's going to be different than the currently approved venetoclax. Um, we talked about some of the the bispecific antibodies. So there's also a lot of data, a lot of clinical trials looking at bispecifics, bispecific antibodies in this setting. And then, there's other things that are being looked at, but I think those are the ones that are kind of like most interesting or closest to getting, possible, use in the clinic, outside of a clinical trial. Other things are being looked at, antibody drug conjugates, meaning antibodies with things attached to them, novel CAR T cell therapies, newer CAR T cell therapies. There's other things that are being looked at, but I think the ones that I just mentioned are the ones that excite me the most.
Very, very exciting. That I really like the idea of the BTK degrader. That is so interesting.
Yeah, no, it's there's a lot of novel approaches and a lot of novel ideas, and it's very interesting, to see in clinic someone who's failed all these treatments, and then they go on some of these medications on clinical trials and see a remarkable response in a very short time.
Yeah. And it's a good reminder to patients also to look into those clinical trials and see what might be available because they might be able to get on a novel medication that could work really well for them. So we'll be sure to have information on the Clinical Trial Support Center that we have in the link below for you and in the YouTube description. Now, our final question today, this program is titled Bloodline Breakthroughs, Innovations and Inspiration. How do you envision the current or future treatments we talked about today changing patient outcomes?
Yeah, I think we've come a long way. I mean, when I was still in training, I remember patients going through, with CLL, going through chemotherapy, having a lot of side effects, a lot of toxicity. We did not even talk about, bone marrow transplants. We used to do a lot of allogeneic bone marrow transplants, for example, for CLL, which we rarely do nowadays with all these novel, approaches that we talked about. These newer treatments have a lot less side effect, a lot of
Good.
and at the same time, they're much more effective than, chemotherapy. And again, we don't really have not really needed to do allogeneic bone marrow transplants nowadays for CLL for a very long time. Allogeneic transplants can be associated with, a lot of side effects sometimes. So I think we've gone a long way in CLL. Obviously, there is still a lot of challenges. So sometimes patients with CLL can transform to an aggressive lymphoma. So we call that
Mhm.
Richter's transformation. And that is an area of unmet need because those patients typically may not respond well to the currently approved treatments. They don't respond well to chemotherapy. And it's an area of, big unmet need at this time. But I think overall, um, looking at all the treatment options available for patients with CLL and the number of approvals through, novel clinical trials in the last few years, it's really been remarkable. And I think, the next few years are going to, we're going to continue to see excitement with, newer agents available. Again, all this is because of the availability of clinical research,
Mhm.
as well as the availability of clinical trials. And it's made a dramatic, effect on patients, with CLL worldwide. There's a challenge with access. So a lot of these medications sometimes,
Yeah.
especially outside the United States, a lot of these medications may not be accessible because of the cost associated with them. And there's a lot of, um, disparities and inequalities, with access with these medications, which is another challenge that us as humanity have to really think about. But again, I think overall, a lot of medications are now more accessible. There's a lot of programs available to make these medications accessible, and I think hopefully in the future we're going to have even more.
Yes, that sounds so hopeful for CLL patients and their families. Well, thank you so much, Dr. Gaballa, for joining us today and sharing all about the current and emerging therapies. And like you said, it seems like there's so many options available to find the right treatment for that patient and for their disease. And so that is wonderful to hear. And we really appreciate you joining us today.
No, no, thank you, Alyssa, and it's really been a great conversation today. And thank you to Blood Cancer United for inviting me for this. Appreciate it.
Yes, absolutely. And thank you to everyone tuning in to our latest episode of Bloodline Breakthroughs, Innovations, and Inspiration. Visit the link below for more information about our topic today, and we look forward to seeing you next time.